So welcome everyone to our fourth set and final set of breakout sessions. This session is about rural hospital closures, what has been and what will be the role of the FLEX program. My name is Tracy Borden. I'm with the National Rural Health Resource Center, so I'm just going to take a minute to orient you to the breakout room here. Again, all the sessions are being recorded. If you have any technical difficulties, please type them into the chat box on the bottom of your screen. You can access the link to that. It looks like a little comment bubble. And our staff from the center, as well as staff from Perform Media, are monitoring the chat box. We can help you out. I encourage you to ask questions and interact with the presenters. So if you have questions during this breakout session, you can type your question into the chat box and we'll see that. Or you can verbally ask the question. So you can do so by unmuting your microphone and asking. But we do ask that if you're not talking, that you go ahead and keep your microphone muted to eliminate any unnecessary background noise. So again, this session is about rural hospital closures, what has been and what will be the role of the FLEX program. And we hope that at the conclusion of this session, you'll be able to differentiate the roles peer programs have had with pre and post closure facilities, identify innovative models that have been implemented in other states, and that you'll be able to compare statewide approaches to the rural hospital closure situation. So I'd like to take a second here to introduce our two speakers. Laura Brooks is the Rural Health Analyst with the Oklahoma Office of Rural Health. She joined the Office of Rural Health in 2014. Her roles include facilitation of community health needs assessments and assisting with quality reporting and improvement activities for the CHs in Oklahoma. Laura previously worked for the Oklahoma Cooperative Extension Service as an extension associate and partnering role with the Office of Rural Health, where she facilitated community health needs assessments as well. She also previously worked for the Federal Reserve Bank of Kansas City as a research associate in community affairs. Bree Watzek has been a pharmacist since 2008, and she joined the Texas A&M Health Science Center in 2011. She is a board-certified pharmacotherapist, therapy specialist, and a Team Steps master trainer. Bree is the Director of Technical Assistance for the Center for Optimizing Rural Health. And the Center for Optimizing Rural Health works with vulnerable rural hospitals to help retain healthcare locally and improve access to care. Part of the technical assistance program is a Project Echo network that's facilitated by Bree. While much of that work, or the work that Bree does, relies upon her pharmacy training, she's become an expert on rural healthcare from a variety of perspectives, including living in many small towns while growing up. Bree is also a National Rural Health Association Rural Fellow for 2020. So welcome to both of our speakers, and I'll turn things over to you, Laura.
All right, thank you, Tracy. And thank you everyone for joining us today. We only have a few slides to go through. When we submitted our abstract in early January or early February, we really wanted to just have a discussion with folks about what you're experiencing and what your role has been in your state. And so with the move to virtual, we're confident that we can still pull this off. So as I mentioned, this is meant to be interactive. We want you to share. We want to learn from you. Opportunity to share experiences of closures in your state, and then what role your FLEX program has had pre, during, and post closures. Discuss some innovative approaches that have been developed, and then compare statewide approaches to the rural hospital closure situation. So a couple things to ponder throughout. And again, we only have about 12 more slides, so we're going to have plenty of time for discussion. But share an example of innovation. So something really cool going on in your state where maybe a hospital closed, but the community is very innovative in delivering care. So needs are still being met of those residents. What's being done? And then also, what's the biggest struggle your FLEX program faces regarding hospital closures? And so just some background. Rural hospital closures, we talk about it a lot, and it doesn't seem like it's getting better. It seems each year, if you look at a bar chart of annual closures, it seems like it's increasing. And we talk about this almost at every meeting we attend, and as I mentioned, it's not one that's necessarily improving. I do have a screenshot of the SHEP Center map here and the rural hospital closure list, which is widely cited. Oklahoma is not immune. We've had a substantial number of closures. So looking from 2005 to present, we had 9 closures. 8 of those happened 2012 through 2019. So that's a pretty sizable number. And I can't remember whose presentation it was on day one, but there was a map in there of the number of hospitals facing high financial distress. In Oklahoma, we were one of the leaders in that one. So it doesn't look like it's something that's going to get improved for us in the near future. But just a snapshot of where our closures are in the state. I will say we've only had one critical access hospital close. It was here in Stigler. They're looking to reopen. They've been trying throughout this calendar year to reopen. So maybe by the end of the calendar year, they will be off the list. But I do want to draw your attention down here to Southwest Oklahoma, the Memorial Hospital and Physician Group in Frederick. We're going to talk more about this location coming up and kind of the motivation for why we wanted to do this presentation and have this discussion. So Rural Renewal Initiative, and I know at one of the sessions, I think it was on day one, where we compared the different state offices, the different flex programs and kind of how you're set up. We're university-based. We are within the OSU Center for Health Sciences. We're actually within the Center for Rural Health, which all falls under the OSU umbrella. And so it was probably about a year and a half ago, our vice president for research had kind of like a call for abstracts to be selected for the Tier 1 research initiative. And so our dean, Dr. Mark Woodring, he is one of the team leads. And I'm trying to think, so the team leads, there's biosystems and ag engineering, rural health, and then we also have agricultural education and leadership and soil sciences. And kind of the thought process was, if we can pull a wide group of folks together with their expertise and really focus on 2 counties in Southwest Oklahoma, can we make a long-term meaningful impact? And so those are the team leads. I'm one of the team members. When you look at the list of team members, we have a wide range of folks. So there's animal science, there's electrical engineering involved, theater, there's nutrition. There's just a wide range of folks that's involved here. We were awarded or recognized, I think it was September 1. Yes? We were awarded September 1 of last year. And so our Tier 1 group is the Rural Renewal Initiative. And so I have a screenshot of our website. Our program has seed grants, and so we're actually working on one of those seed grants for one of the counties where they actually lost the hospital in 2016, that Frederick Hospital that I just mentioned. There's also a Rural Scholars Program where it was about 5 scholars lived in these counties during the summer and kind of assisted with research. So we had a rural scholar working with us. She was our boots on the ground to distribute surveys and do interviews. And then we also have the Rural Renewal Symposium. So the first one is scheduled for October 13th this year. And like many other conferences, it'll be virtual. So I wanted to plug it. I don't know. I'm all about this virtual learning. I'm signing up for everything I can. I love it. So the registration's not available, but it will be on that site. So one of the focuses is on Tillman County, where I just mentioned the only hospital in the county closed in 2016. So a little bit of information about Tillman County. As I mentioned on the previous map, they're located in far southwestern Oklahoma. According to the USDA ERS county dependency codes, they're categorized as a farming dependent county. And in particular, they're really big in dryland cotton and cattle beef production. They're categorized as a persistent poverty county. Their current population is about 7,600. However, their peak year was in 1930. So they've continued to see a decline in population since 1930. As I mentioned before, their hospital closed in 2016. Their hospital, when it was open, they were a 37-bed licensed facility, a PPS facility, and they did look at critical access designation. Unfortunately, there were 31 miles to another facility in Texas, and those were all primary roads. So, but they did reach out to our office prior to closure to see if it was feasible. Fortunately, they're not starting from ground zero. When the hospital closed, there are some entities still present. When the hospital was open, the nursing home and the hospital were under the same entity. The nursing home is still open, and actually the hospital board still meets because they still have the nursing home. So that's pretty exciting for us because there's a group of folks who understand the history, but also have a very vested interest in healthcare that are meeting regularly. There is a clinic and then also a county health department present. So with all this background information, we wanted to look at what are some cool, innovative things that other similar counties are doing or similar locations are doing where our goal is ultimately to go back, have stakeholder meetings in that community and say, hey, here are some things that we learned. Which one or bits and pieces of one would you like to implement here in your hometown? Which one do you feel like would be the best fit? So what we did is we used the rural hospital closure list. We pulled some variables together to try to find some comparable or similar counties. I will say when I first did this, it was very, very restrictive, and I didn't yield any comparable counties. And so I had to widen the range out. So our comparable counties, we're looking at a poverty rate of greater than 15%, a population of less than 26,000, and they're categorized as non-metropolitan. As I mentioned, I was too restrictive in the beginning, so we had to widen our parameters. This yielded us 28 similar closures throughout the country. And so then the next steps were reaching out to each state office of rural health to get more of the story. So as I mentioned at the bottom, this was literally the best part. This was so much fun. To reach out to each state office and, tell us a story. What led to the closure? And, we're all very similar is one thing we learned. But also what's going on now. And during these calls, this was in December and January. And during these calls, I was like, man, I wish other people could hear like just what we're learning. And so that was kind of how this idea came about was, we're hearing all these cool stories and this great conversation. What was I going to say? And that's also possible, probably why I widened my parameters was to get to keep calling state offices and sharing and learning from them. But nonetheless, we did end up with 28 closures. I have a map of all the locations of the closures that met our parameters. So these were all the state offices that we reached out to. On our map here, we have the star, that's Frederick. On the next slide, we did identify 3 locations to actually go visit. That was through talking with the State Office of Rural Health, talking with partners in that state, and then also searching through like news articles, trying to get a little background information. As I mentioned, we worked on this in December 2019, January 2020. So our plan was to identify our locations, to go visit in person, do interviews, just walk around town and learn. We've had to postpone that. We're now looking at doing that in summer 2021. The 3 locations that stood out to us were Belzone, Mississippi. Their hospital closed, but there's a relationship with Ole Miss and Mississippi State where there's actually a clinic and the extension office are all together. And so you can have patient education, great outreach. And so since we're university-based and actually cooperative extension is with us, we thought, this is something we really want to explore further. And so that's on our docket for summer 2021. Trinity, Texas, Bree is going to talk more about Trinity. And then DeQueen, Arkansas. And this actually, DeQueen came about from talking with Sherry and Harold. They shared, they have a clinic. They have a clinic in this town. The hospital closed, and the clinic was led by 2 great individuals that said, we need to do more. We need to fill that gap. We need to expand what we're doing. And so we do want to go next summer and meet with all these individuals in person. And again, as I mentioned, we want to go gather as much data as possible and then host town hall style meetings in Tillman County to share our lessons learned and then which model or combination of models would they like to implement in their community. And so again, please ponder those 2 questions that we started with because we're going to have plenty of time to share and just bounce ideas off of one another. And so Bree, I'll turn it over to you.
Thank you, Laura. Well, they say everything's bigger in Texas, and so we have lost more hospitals than any other state. 24 closures since 2005. We've lost 1 so far this year. Now that being said, we do have more rural hospitals than others. So I think if you do percentage of those that have lost, Tennessee might be ahead of us. I'm not sure how you want to, we really don't want to compete in this area, but Texas has lost quite a few, and that's where Trinity comes in. I want to tell you a little bit about the story of Trinity. So there we go. So Trinity is in East Texas. Texas is big, so we're talking East Texas. A basic breakdown of Texas: West has more oil, therefore more money, east has less. Therefore, we tend to see more hospitals struggling. So Trinity is considered a health professions shortage area with fewer providers than needed for the population. And we went and visited Trinity several years ago. So to give you the history of Trinity, they started out with a 26-bed hospital that was providing care for the residents since the early 1950s. And prior to closure, they'd been managed by a large hospital system that operated several small rural hospitals across the region. And so the system was presenting numbers at board meetings, and they thought everything was going well. The community wanted to financially support their hospital, and so they voted and approved a taxing district for, in Texas we have hospital districts where you can have a tax, and so the community was supporting it through their tax dollars. The board looked at financials at every meeting, and they will say that they didn't know what they were looking at. So that's one lesson I can tell you about the story of Trinity is the board, they were good people. They were trying to help their community, and they didn't understand the financials, and the system was able to show slides that made things look good, and they didn't understand how to ask the hard questions. So for those of you that offer board education to your hospitals, thank you. That is a very great need. So anyway, so the system decided after they'd managed the hospital in Trinity for 18 years, but due to low utilization and declining reimbursement rates from Medicaid and Medicare, sound familiar, I'm sure, to many of you, the system could no longer or would no longer afford to operate the hospital and the clinic. But they said that they had a 2-year run time, and so they let the board say, hey, 2 years we're going to leave. You guys have 2 years to figure this out. And the board was surprised. They had no idea that this was happening. Again, they didn't understand the financials presented in their meetings. And so during those 2 years, they deliberated and they sought out funders for the hospital. And they thought they had somebody, and about a month before the 2 years ended, the person that they thought that was going to purchase the hospital backed out. And so the board again reflected, what did we learn? And what they learned was they were in a stronger position 2 years ago than they were at the end of the 2 years. So they should have sold sooner and had less deliberation. So again, board education. These are pictures of the lovely facility at Trinity. And so I just wanted to show you that it was beautiful and state of the art. And they closed. And so what the board was able to do was, after the hospital deal fell through and the hospital closed, they also had a hospital 30 miles away in Crockett that also closed at the same time. But they were able to, the board was able to negotiate with a group to run the clinic, right? Because they'd had a hospital and a clinic. And so they were able to keep the primary care clinic open and providing care to their community. Fortunately, Crockett, the town 30 miles away, was able to get another buyer to reopen their hospital. And so they've made that work, where they have, they address most of the needs of the community through the primary care clinic, which they were able to open. And then they lucked out that Crockett was able to open their hospital. So that was kind of reframing the right size of, do we need this 26-bed hospital 30 miles away from another critical access hospital? Or can we meet the needs of our community and on a budget with the clinic? So they're doing well right now with the clinic. So that's the story of Trinity. I wanted to also show you what the Texas Flex program is doing for our hospitals in Texas, since we're struggling. And I know they're doing many things. So Robert, I'll have you fact check me. But one of the things that they did, they rolled out earlier this year, was this MBQuip portal for the hospitals in Texas. And this came as a request from the hospitals that said there's too many places to go, too many deadlines. And so this is, it's not new, but what it did is it's one-stop shopping. So you've got the QNet, Nissen, and MBQuip database for Texas all in one location. It's got all the deadlines that come up. It's got links to Stratus Health and other MBQuip experts, as well as webinars and educational materials. So it's one place that they can just bookmark and go. And they said that that's helpful, that we reduce the burden of keeping up with the different regulatory requirements by having the one-stop shop. And that was funded by the Texas Flex program. And then I'll turn it back to you, Laura, for discussions.
All right, thank you, Bree. As I mentioned, we tried to allow as much time as possible, but we really want to hear from you guys. As I mentioned earlier, having those phone calls with other state offices was so beneficial for me. And so I wanted to open it up. Here's some questions to think about. What are some of the leading factors for hospital closures in your state? As I mentioned about Frederick, they had a dwindling population into persistent poverty county. We have some of those. We also have some kind of outliers in our state, but what are some of the leading causes? Then, share what you're proud of. What are some innovative, some creative ideas that communities are taking in your state to meet the healthcare needs of your residents? And then also, what role is your flex program? What role does your flex program have in developing and implementing these programs? And then also, what opportunities do you see moving forward? Because as I mentioned, in Oklahoma, it doesn't look like the situation is going to just magically change overnight for us. So I think this is something we'll possibly be seeing more of in the coming years. So with that said, I'd like to turn it over to you guys so we can learn from you. So who would like to share first?
While we're waiting for people to not be shy, I think one of the struggles in Texas is that we did not take the waiver expansion. And so it is hard for our state, the critical access hospitals especially, to cope. But I saw that Missouri voted to expand effective next July, June 2021. So good for them. I'm hoping that'll help the hospitals in Missouri, but it's a long time coming to get a legislative change.
And actually, Oklahoma voted in June to expand as well. So hopefully that'll make an impact for us as well. So I guess let's take a step back. Does anyone have an example of innovation in your state where a hospital is closed and they're delivering care differently?
This is Jennifer in Kansas. I can talk about one situation that we have had. This was actually a PPS hospital, though, that closed, a small rural PPS, not an SCAH. But a local community nearby that has a hospital has opened in basically an extended campus. So they have an ER, a physician clinic, and some other kinds of services that they're providing. So it's been very beneficial for the community. I will say the financial impact on that main hospital has been challenging. It's costing a lot more for them to do that than what they anticipated it would. And we have a number of small PPS hospitals in our state that would benefit with a CAH status, but the mileage prevents them from being SAH. So I'd say that's one of our biggest challenges. If we could get that mileage rule changed, that could really help some of our folks.
We have so from 2006 to 2016, we were at 34 critical access hospitals. 2016 through 2018, we actually increased by 6 critical access hospitals. But as it stands right now, the mileage, unless there's substantial changes, the mileage is what will max ours out at the moment. But I did want to ask also, there's the Rural Hospital Closure Relief Act that's possibly coming up to open up necessary provider again. Is that something, are other states making preparations for when that does pass? Or I guess what are you doing? And then Jen Edwards just commented, I think the Pennsylvania rural health model, I think the Pennsylvania rural health model has also significantly helped the participating rural hospitals. Good, that's good, good deal. Ronnie Rom, similarly, we had 3 rural PPS closures in Massachusetts, and they all became very active satellite EDs and outpatient services. We are currently trying to bring community paramedicine to at least one of those areas. Ronnie, what else? Do they just offer the standalone ED, or, and also are they part of a system? And then let's see, Jennifer said we have a few that would benefit from the passage, allowing necessary provider again. And then one hospital closed at the Arizona border, another critical access hospital nearest to them opened a freestanding ER in the community that's also designated as a level 4 trauma center. And then Ronnie said, yes, those are all part of systems, the standalone EDs. So standalone EDs is something that we thought were really interesting. And so we've been trying to get more information about, how those are funded, or are they system, just kind of the setup there. And then Jennifer's freestanding ED was not system related. Jennifer, would you mind sharing more information? Oh, you just talked about that one, sorry. What else?
So also in Kansas, I saw a really unique model. This is Bree, that Harper, Kansas, and
oh yeah, I can talk about
Anthony,
that.
Kansas. Yeah, I mean, you guys got a lot of money, but still, that was impressive.
Yeah, so we had 2 hospitals 15 miles apart. Both had CAH status, had gone through, way back the conversion process. We were very, very good in our state in doing the necessary provider when we had that ability. So we have 83 critical access hospitals. We've lost a few, so we're down to 83, but we were very, very good at converting when we had that opportunity to do so. But these 2 hospitals they're in the same county. They were both funded by county tax support, and were coming to the conclusion that their population was just so small, they really didn't need 2 hospitals 15 miles apart. And we're very fortunate that they had a very wealthy benefactor who came from one of the communities. He is actually the owner of Cerner Health Systems. He's now passed away, but he was the owner of Cerner. And so he came to the communities, both of them, and said, I will build you a brand new hospital if you can figure out how to merge. So those boards had a strong motivation to work together. It was a long process. They did a lot of hard work. They had, because of those financial resources, had some outside consultants and other governance, type folks that really helped them through that process. But they have successfully merged. They have a new, beautiful hospital that sits right smack dab in the middle of the 2 communities, kind of out in the middle of a field, in the middle of nowhere. And they are now they're operating now, and blending 2 staffs and things like that is kind of what they're working on. It also was somewhat of an unusual circumstance, because as we started looking at COVID and how we might need extra bed capacity, we had these 2 existing hospitals that were sitting empty. So it provided a nice little extra, hey, we have some more beds somewhere if we really truly need them. Or spots that we could move beds to pretty easily. But it's been successful for them, but it was also a multi-year journey, and it took a lot of community conversation and trust, and some really, really brave board members to step forward and suggest they do this.
That's really cool. And what a good model of the collaboration and regionalism that they display. Are there any others that folks would like to share? Or what opportunities do you see that, like, flex coordinators and flex personnel like we have moving forward, working with hospitals in terms of closures?
I've only had to ever deal with one potential hospital closure, and it was basically the work of the Flex program that, 1, kept it from closing, and 2, helped the improvement afterwards. And it was basically, when they announced that they were going to close, well, the state still wanted an ED facility out there, and I basically pointed out that the amount of money that they wanted to run just an ED facility was the exact same amount that they were asking for in support to maintain an ED facility and a hospital and clinic. So basically, you can either pay $3 million and have a ED facility, or $3 million and have an entire hospital. One of the reasons why they probably were about to close is that they kept the Flex program at arm's length, because once they declared bankruptcy and we worked to get them under. They declared bankruptcy. The CEO, the whole C-suite left after they declared bankruptcy. bankruptcy, and we brought in new management was brought in that had worked with us with other critical access hospitals. They brought us in, and we were able to do a proper assessment, and we found that they were leaving so much money on the table that if they brought us in earlier, they probably never would have had to declare bankruptcy. So I don't know what to do with a hospital that continually keeps you at arm's length because they mistrust you, because in our case we're a government organization. But now they're one of our top performing hospitals in the state in terms of critical access hospitals. But that, that's the only issue. That's the only time that I had an issue. And basically, in order to keep it open, it was just basically bringing up a lot of data, showing the trend data that despite that they were losing money over time, that since the Flex program was implemented, even though they were keeping us at arm's length, they were taking some of our advice, so they were slowly improving. That's all I have to offer. Sorry.
We can definitely relate. Some of our hospitals in Oklahoma that need the most help are the most difficult to get in touch with. They're not volunteering, they're not attending such our programs that we do. So yeah, we share your frustration.
I would also say that the mileage requirements would also help, because probably the hospital that's most at risk now is a PPS hospital, but they would like to convert to critical access hospital, but they're too close to a critical access hospital that came in under the necessary provider provision. So.
Bree?
Yeah, so I was going to give a shout out to the Florida Flex program. They had 2 critical access hospitals that were struggling, and they actually completed the application for them. I work at a HRSA-funded technical advisory center, and Abby Parmenter and Layla Shepard filled out the application on the hospital's behalf to get them into our program. So that was kind of like pulling them to water, right? You can't lead a horse, but you can pull them. So I appreciated that. We've enjoyed working with our hospitals this year, but that was kind of, if you don't trust me, here, work with these people.
All right, does anyone else have something innovative or a struggle, or just what you see our future role will be? All right, well, hearing none, we'll let you out a couple minutes early, take a break before the closing session then. Tracy, is there anything that you wanted to add?
No, nothing. I thank you both, Bree and Laura, for presenting. We definitely appreciate it. I think it's good things for us to ponder. I think that rule, definitely agree, will make a big impact in a lot of states. So we'll see what happens with that if it becomes implemented. So yeah, well, we have a break, and so we'll actually start again. You guys get the extra special break. So we'll start again at 1:15. There'll be a plenary session, so you'll go back to the portal and into the player. We can post a slide up here that'll have the link to that too for your use, and that'll be our closing keynote session. So it will be the title is Seeing 2020 Experimentation, Innovation, and Opportunity. So it'll be about leadership, and we have a presenter coming from the Studer Group. So I encourage you to join that at 1:15 back in the main player room, but we'll get a link posted in here too, so you can access it there. Thank you guys.